And so there are 1, 2, 3, 4, 5, 6, now 7 statin drugs out there. So atorvastatin is Lipitor, that's the one everybody on television is taking, including football coaches and who knows what else. Important people apparently are taking Lipitor. Rosuvastatin, which is Crestor. Crestor is the most potent of the statin drugs. And I find that if you have problems tolerating statins from a muscle ache standpoint, it is probably the most tolerable of the statin drugs. So I don't use it first, but I use it in people who don't tolerate the other statins. Then there's fluvastatin, lovastatin, pravastatin, and simvastatin. The nice thing about these 4 are they're all generic. Simvastatin is the best bang for your buck. So for a given percentage lowering in your cholesterol, it's the cheapest per percent drop in your cholesterol.
What's the name of that last one?
Simvastatin, also known as Zocor, has probably the best bang for your buck. But all these are generic. These are the absolute cheapest. These 2 are not generic. Lipitor is going to be generic soon. I think in the next 6 months. Lipitor is going to be generic. And then everybody's going to get switched to Lipitor. Huh?
They've said that for several years.
Well, they got a patent extension and now that's done. So their patent's good for 17 years and then they got a patent extension for like a year or 2. They give them money, government money, and they get a patent extension. But that's running out, and so it's going generic. I don't know what the exact date is, but when it does, everybody's going to get switched to Lipitor. And the reason is it has a dramatic drop in your cholesterol, and once it goes generic, it'll be the best bang for your buck. But right now, most people are on simvastatin because it's the best bang for your buck. It's the most effective generic. Again, rosuvastatin, which is Crestor, is probably the best tolerated. And there's a new one that came out last week. That's not even on the slide. It's so new. It came out 5 days ago, which is Levolol is the brand name. I don't know what the generic of it is. And I don't know all the data on it, so I didn't put it on my slide because it came out 4 days ago. And I haven't used it yet on anybody. But apparently it's being billed as being as strong as Crestor with low side effect profile like Crestor. So it'll be a kind of second drug. And so this is just a summary. They've studied hundreds of thousands of patients with statins. No drug in the history of the FDA, as far as I'm aware, has been more studied than statin drugs. And this is just a summary of some of the big trials. These are 20, 30,000 patients that are in these groups, looking at risk reduction from various things. So people who've never had a heart attack, these are these first 2, who've never ever had a heart attack before, and they put half the group on statins and half the group not on statins, it reduces your risk of having either a stroke or a heart attack by anywhere between 30 and 40%, which is huge. Huge. There's very few drugs that'll have this kind of turnaround. These are people who've already had a heart attack. These are just 3 studies, but they've done 20 studies, 50 studies. Again, your chance it reduces your risk of having a second heart attack by 20 to 30%. And then people who have angina, basically, it reduces your risk of even angina or heart attacks in people that have angina by 30%. So across the board, it lowers your risk of dying by 30% or so. So they're incredibly effective drugs. We've got a lot of bad press out there, and most of it's not warranted. So this is just another look at things. So this is statins in general will reduce your risk of having a heart attack by 30%. It'll reduce your risk of stroke by 25 to 30%. And it'll reduce your overall chance of dying by 20 to 25% because it reduces your risk of heart attack and stroke by so much. And there's other benefits to it too. There's some benefit as far as preventing Alzheimer's dementia, atrial fibrillation, non-ischemic cardiomyopathy, lots of other different things beyond your cholesterol, beyond heart attacks and strokes, and very few downsides. But there are some real downsides, and we've got to cover those as part of this talk. So the biggest side effects of statin drugs are muscle aches. That's probably the #1 reason why people stop taking them. Some people get headaches, fatigue, GI intolerance, but the big thing is myalgias, which is just a medical term for muscle aches. Liver problems occur in about 1% of patients. That is why if you're on a statin, the recommendation is you get 2 small liver tests once every 6 months. Again, if you take fermented red rice yeast, you have the same problem, so you should get your liver checked if you take fermented red rice yeast. If you're taking non-fermented red rice yeast, you're wasting your money. Serious liver problems, like full-blown hepatitis, are very, very rare. I've been here for 4 years. We've had 1 patient in 4 years that has had that problem. So just in Whatcom County, we've probably given statins to somewhere on the order, 40,000 people. And we had 1 full-blown liver hepatitis. Actually 2. And both of them almost died. But you take them off the statin, it goes away. But still, that's why you check your liver every 6 months, because you can catch it early by checking the blood test every 6 months. And the people that get to that point are people that have not been followed. Muscle problems occur in, the official line is 0.2 to 0.4%. I think it's higher than that. It depends on the statin. Again, Crestor probably has the least problem. It's also dose dependent. So if you're taking 80 milligrams of Zocor and you get a little bit of muscle ache, if you drop down to 40 milligrams, you're probably not, the muscle aches will probably go away. So the higher the dose, the more chance you are to get both liver problems or muscle problems. And the other thing is you don't gain a lot. You gain some as far as lowering your cholesterol on the higher dose, but you don't gain a lot. If you go back to this slide, so like the difference between 40 milligrams and 80 milligrams, you drop 10 points. You go from 50 to 60%, so you don't get a huge.
This word. What does this mean?
Rhabdomyolysis. So yeah, that's a good question. So muscle aches occur in 0.2 to 0.4% of patients. This is a good question. What is rhabdomyolysis? That's a very serious problem from statins, where you actually get muscle breakdown, and your muscles basically start eating themselves is not a good way to put it. They basically just break down to the point that your muscles start withering away, and all the protein in your muscles can plug up your kidneys, and you can go into kidney failure. Rhabdomyolysis is extremely rare, but it is the reason that if you start getting muscle aches when you start taking a statin, particularly if they're severe, that you need to stop your statin right away. Those muscle aches and this idea of muscle breakdown, which is rhabdomyolysis or muscle breakdown, will go away when you stop the statin. But that can be quite dangerous. So if you get it, just stop your statin cold turkey, call your doctor. When you're talking about muscle aches caused from statins, and in particularly when you talk about the muscle breakdown, the serious stuff, where it affects you is the big muscles, your thigh muscles, your hamstrings, and your shoulders. So if you're getting little cramps in your calves, that's not your statin. That's low potassium. Sometimes people get joint pains with statins, but for the most part, it's the big muscles, your trunk muscles that get sore, and it's just kind of this achy, sore feeling that's always there. It's not cramping in your calf muscles that occur at night. That's your potassium. It's just a sore, achy thing that they just can't get rid of. And that can be dangerous too. And that's particularly problematic in people taking both a statin and a fibrate. So we're going to talk about fibrates next, or sometime in here. And that particular combination, statins and fibrates, are where most people run into the muscle problems, as far as the dangerous muscle problems. All right, so that's my little soapbox on statins. A fairly newer product is the Zetia. So Zetia works very different from a statin. It basically blocks the absorption of cholesterol in your intestine, so you don't absorb cholesterol, so it never gets into your system. It lowers your bad cholesterol, it raises your good cholesterol, and it lowers your triglyceride. It lowers your bad cholesterol by about 20%. It does not have any of the liver problems that statins have. It doesn't have any of the muscle problems that statins have. And it's much better tolerated. The only problem with Zetia is there's not much data, or there's no real data. That's not true. There's one study now looking at outcomes of improvement with Zetia. That is, there's no proof that even though it lowers your bad cholesterol, that there's no proof that it lowers your chance of dying of a heart attack or stroke. And it's mainly because they haven't done the studies. They did one study looking at the thickness of plaque in people's carotid arteries, and found that it did not lower the thickness of the carotid artery plaques. And that got published in the New York Times as Zetia doesn't work for anybody. And it was a huge thing. It was all over the news about a year and a half ago. And it wasn't even an outcome data with cardiovascular events. It was just a measure of the plaque in the carotid. So nobody really knows how effective it is, other than it lowers your cholesterol. So I don't use it as a first-line drug because of that reason. And most people have stopped using it in general, except for people who don't tolerate statin drugs and need to lower your bad cholesterol. So the times I use it is people where you can't get your bad cholesterol down low enough with a statin alone, then I'll use it. And I'll use it for people who don't tolerate statins. But I will not use it usually as a standalone drug. So two other kind of categories, bile acid resins and fibrates. So bile acid resins are old. They've been out for longer than statins. They were one of the original cholesterol-lowering drugs. So they come under the brand names Welchol, Cholested, and Questran. I think most people are on Welchol. They have good data as far as reducing your chance of dying of a heart attack or stroke. The problem is that you get a lot of GI side effects. You get flatulence, which is, you know what that is, right? Burton. You get abdominal pain, constipation, bloating, and most people cannot tolerate these drugs. But for some people, they've been on it for a long time. For 30 years, I've had some patients on it. They're convinced that it's, and they're fine with it. I'll leave them on. So that's just a graphic representation that if you take it, it'll lower your cholesterol by 15 to 20%. Fibrates are kind of like, I use a little bit. So there are now 4 different fibrates: gemfibrate, fenofibrate, trilipics, and tricor. These, like fish oil, are mainly designed to lower your triglycerides. They will also raise your good cholesterol a little bit. The side effects are also stomach stuff. And again, if you mix fibrates with a statin, that's when you can run into muscle problems, so you have to do that. And I do that in a couple patients, but you have to do that very cautiously and make sure that people are very aware of the muscle aches and muscle problems and to stop the drugs if they get those. So just a summary, I think this is 5 slides, so if you fell asleep on all the other stuff, wake up for these 5 slides because it pretty much cause a fail. So this is a graph that I expect you to memorize, summarizing all the different drugs and what they do. If you memorize this, you'll know more about cholesterol than probably 70% of doctors out there. But the main things to glean from this is that for bad cholesterol, the best thing are statins. And for good cholesterol, the best thing is niacin. And for triglycerides, the best thing are fibrates or fish oil. And I'm going to say that again without the big graph with all these numbers on it. That's confusing. So just to summarize bad cholesterol, that's your LDL cholesterol. LDL means lower. It's an easy way to remember it. If you have heart disease, you've had a heart attack, you want your number to be 70. If you're at high risk for a heart attack, that is, you have vascular disease or you have diabetes, your goal level should be 100. If you have 2 or more risk factors, it's 130. And if that's your only problem is cholesterol, it's 160. The treatment, as far as I'm concerned, is statins. If you don't tolerate statins, then you need to, see somebody that specializes in a little bit in cholesterol to try some of the other stuff. HDL, the H stands for higher. That's your good cholesterol. The higher, the better. Men greater than 40, women are treated unfairly and need to be greater than 50. And the treatment is exercise and niacin product of some kind. Triglycerides, everyone should be less than 150. If you're 200, 180, I don't get too excited about it. It's the least important of the 3 major lipids that we look at. Treatment is primarily diet, low starch, low sugar, weight loss, particularly if you're big around the stomach, and then fish oil and fibrates are effective at lowering your triglycerides.